Hey, it's Dr. G. Welcome back to Discussions with Dr. G, where today we're pulling back the curtain on safe medication practices. Now, let me start with this. Nurses are basically the last bouncer at the club before meds get inside the party. Seriously, there's the provider, the pharmacist, everyone down the line, but you, the nurse, are the final checkpoint. If something goes sideways, it's often us that catch it. No pressure, okay? Let's talk about the types of prescriptions you'll actually see when you hit the floor. You've got your standing orders. Those are your keep giving this until you hear otherwise type of order. Stat orders, which, fun fact, come in faster than my cats when they hear the treat bag. Then you've got PRN or pro nata, or as needed for you non-Latin speakers. And finally, your single dose or one-off orders. Each one has its own urgency, rules, and could trip you up, especially in a code situation. A quick mini rant. Time. If I never see a 1 p.m. written as 1 o'clock again, I'll be happy. Always use the 24-hour clock in healthcare. 1300, not 1 p.m. And trust me, at 0100, after a double shift, your sleep-deprived brain will thank you for not mixing up AM and PM. And measurements. Please don't use grandma's kitchen spoons. Metric system is your new best friend. Milligrams, grams, milliliters, liters, all that good stuff. Household stuff is fine if you're teaching patients at home, but at the bedside, stick to metric only. I once had a student argue that her teaspoon from home was about the same. It is not, folks. Do not fall for it. All right, let's roll up our sleeves for the math part. Don't tune out. I promise I'll keep it real. Dosage calculations. There's a lot of drama here. Maybe not as much as med-surg unit on a full moon, but close. So there's really three main ways nurses get these calculations done. Ratio and proportion, that's the classic old school cross-multiply technique. The desired over have formula, which is just a fancy way of saying what you want over what you've actually got times what you need to give. And then dimensional analysis, my personal favorite, which is all about canceling out units until hopefully you're just left with the dose. Now, in real life, you're going to run into special populations, pediatrics, oncology, critical care, where dosing isn't a one-size-fits-all. It's based on weight, usually milligram per kilogram, or in some cases, body surface area, or BSA. So you'll see things like chemo drugs in milligrams per meters squared. Okay? When in doubt, double check your decimals and always get a second verifier. Rounding. This is where folks slip up. If your answer is less than 1, round to the nearest hundredth. But if it's a big boy, over 1, go to the nearest tenth. Tablets, round to the nearest half if they're scored. And with IV rates, if you're using a pump, you can keep it to the tenths. But gravity, you have to round to the whole drop. The math doesn't lie, but sometimes it does try to mess with you. Let me tell you about this time at shift report. A nurse, bless her confused calculator, read off that she'd calculated a dose of 15 tablets for a patient. I mean, come on. Even my cat would look at that and think, no way, human. That's why you have to stop and look at the number. If it sounds wild, it probably is. All right, so let's get a little heavy with medication errors. Not just the stuff of legend. These are preventable things that happen when prescribing, dispensing, or administering meds. The usual suspects: giving the wrong med, wrong dose, wrong patient, wrong route, or at the wrong time. Don't forget the classic math mistakes or copying the wrong order into the chart. Yep, been there, nearly done all of those, if I'm being honest. The thing is, errors don't always come from just one person. There's individual, what we call active failures, like a nurse giving the wrong pill. Then there's latent failures. These are deeper system level stuff like terrible lighting in the med room or confusing labels. Picture the Swiss cheese model. Holes in each cheese slice or gaps, and sometimes, if they line up just right, that's how an error sneaks through. But we aren't helpless. Technology is our friend, most days. CPOE, Computer Provider Order Entry, means no more chicken scratch handwriting. BCMA, Barcode Medication Scanning, keeps you from giving Mr. Smith's Tylenol to Mrs. Smith down the hall. And smart pumps guard against infusing the oops dose. Protocols like the Joint Commission's Do Not Use list or the Institute for Safe Medication Practices, ISMP, these lists are your safety nets. And the 10 rights of medication administration, memorize them. No, tattoo them on your arm. Just kidding. Maybe not. I'll never forget the first time I filed an incident report. My hands shook. I was convinced I'd be called to the boss's office for execution or something. But actually, nothing really bad happened. Why? Because reporting is how we get better. If you're afraid to speak up, nobody learns, and the system stays broken. On my last unit, things really improved after we started using the team's steps. Team strategies and tools to enhance performance and patient safety. SBAR, situation, background, assessment, recommendation. CUS, concerned, uncomfortable, safety. These are all communication methods. STEP is used to keep track of patient status of the patient, team members, environment, and progress towards the goal. These are all part of the Agency for Healthcare Research and Quality, AHRQ. Suddenly, everyone's on the same page, and it just feels safer. So remember, as challenging as safe medication practice can be, the right combination of technology, protocols, communication, and just plain guts can shift a unit's whole culture. That's it for today. Go double check those calculations for me. Catch you next time.